Kia ora. Welcome to these presentations where we're just delving into the characteristics and to some degree the significance of atrioventricular blocks. All the AV blocks have one point in common. That is that they're all produced by the slowing down or the blocking of impulses in the AV node. In other words, the signals that are leaving the atria become sluggish or they are blocked before they can reach the ventricles. This means that the atria and the ventricles are functioning normally, but there's some loss of coordination between them. There are three types of AV nodal block, and their name, first, second, and third degrees, suggests some sort of hierarchy. So a first degree block is characterized by just merely slowing down of the signal through the atrioventricular node, and it's not an especially worrying thing to find for a patient. On the other hand, a second degree block is going to involve both the slowing down and some degree of block in the AV node, and this is cause for greater concern. And finally, the greatest concern is associated with the third degree blocks, and it's these ones which are characterized by a complete malfunction in the AV node. So the rest of this presentation is going to give an overview of the characteristic for each of these types of blocks, as well as some insights into their clinical significance. And we'll start with the first degree blocks. By definition, a first degree AV nodal block is a sinus rhythm with a PR interval that exceeds 200 milliseconds or 5 small squares on a standard ECG recording. Now, I want to reiterate the two qualifying factors for this rhythm. Number one, the underlying rhythm has to be sinus in origin. Secondly, the PR interval must exceed these 5 small squares or 200 milliseconds. So let's look at this rhythm here. It's a regular rhythm with an underlying rate of 55 beats a minute. The upright and rounded P waves in lead 2 and the 1-to-1 conduction ratio between the P waves and the QRS complex indicate this is a sinus rhythm. Now, the rate is bradycardic, so we may call it a sinus bradycardia, but in essence, it's still a sinus rhythm. So as we come down our 5-step method and look at the PR interval, we're going to find that this is somewhere between 8.5 and 9 small squares. So if we were to multiply this by 0.04, we're going to find out that the PR interval is in fact 316 milliseconds long. So we have satisfied the two criteria. Number one, there's a sinus rhythm, and number two, that the PR interval is greater than 200 milliseconds. First degree blocks can be a result of physiology. In other words, a normal finding, which might be the case, say, with an athlete who tend to have parasympathetic dominant fitness. The AV node contains many parasympathetic nerve endings. So parasympathetic stimulation is going to slow the speed of impulses through the nodal tissue. This is going to equate the longer transmission time and hence the longer PR interval. Now, another common cause for first degree blocks is pharmacology. So in particular, patients that are using beta-adrenergic blocking drugs, say something like metoprolol, for instance, or any of the other beta blockers, the sympathetic nerve endings are going to be blocked, and this allows the parasympathetic system to be dominant. So again, the rate of transmission is going to slow down, and this is going to increase the PR interval. The pathophysiological causes of first degree block mostly are associated with the formation of fibrotic tissue or scar tissue within the AV node. Now, this is really common in aging. So again, first degree blocks as people get older are not necessarily an uncommon finding, but they can also be associated with structural disease of the heart, and less commonly it might be illnesses such as Lyme's disease that causes fibrosis or scarring around the AV node. First degree AV blocks are considered benign, and in terms of cardiac output, this is quite correct. The delay in transmission has minimal effects on ventricular filling, and therefore ventricular performance tends to be unaffected and cardiac output remains unaffected. First degree blocks are predictive of worse long-term outcomes where the block is persistent. has been associated with a greater likelihood of the onset of atrial fibrillation and heart failure, but in the acute setting, not a worrying sign per se. So, what does this mean for paramedics? Firstly, the presence of an AV block is not worrying in terms of cardiac output. If you should encounter a patient with poor perfusion and a first-degree heart block, you've got to assume there's a bigger problem going on than the block itself. So this brings us to the second-degree AV nodal block, and there are two main subtypes. Now, both are characterized by a partial blockade, or in plain language, some atrial signals are going to result in ventricular depolarization, and some will not. So, in both of these subtypes, we're going to have more P waves than we are QRS complexes. Now, the two subtypes are known as type 1 and type 2, very imaginative. Sometimes they're called Mobits, and type 1 is sometimes called Winky-Barker. But to keep things simple, we're going to refer to type 1 as type 1 and to type 2 as type 2. So, let's have a look at type 1. The main characteristic of a type 1 second-degree AV nodal block is a progressive lengthening of the PR interval, and that this in the rhythm is going to culminate in the odd dropped ventricular beat. Now, the pattern will often repeat, and there's often a fixed ratio of P waves to QRSs in this pattern. It's probably easier to look at this on an ECG than it is to try and describe it. So the first thing that you might notice about the rhythm on this ECG is that it's not regular. And if we were to examine this a bit further, there's a suggestion that there's some sort of repeating pattern. So we would call it a regularly irregular pattern. The ventricular rate for this pattern is around about 70 beats a minute, but the atrial rate is slightly higher. It's almost 80. Now, if this isn't apparent to you, don't worry, because we're going to pick up the significance of this as we go down through the 5-step method. Now, the P wave is rounded. It's positive in lead 2, and so we can assume that this is sinus in origin. We've already worked out that there's more P waves than there are QRS complex, and this one fact on its own is enough to make me consider a very strong possibility of some type of second-degree heart block. So the only decision left to make now is which type. The telling point is going to be in the PR interval, and this emphasizes the importance of checking more than one of the PR intervals on any given rhythm strip. So what we can see here is a progressive lengthening of the PR interval and then a dropped or a missing QRS complex. Let's look at this one more time. First-degree block could be considered to be a tired AV node. Because it's tired, it takes longer for the signal to pass through, and hence the PR interval is longer. With a type 1 second-degree AV block, we could consider the AV node to be more tired again. So there's going to be a delay for the first signal going through the AV node, but in the case of these type 1 blocks, the delay for the next signal is going to be even longer, and so on, until the node becomes so tired that it can't send a signal at all. This is where we see the dropped QRS. Now, when this occurs, it actually gives the AV node a bit of a short break, and the AV node is going to be able to recover to a certain degree. But after it transmits the next atrial signal, the cycle is going to start all over. So let's look at one more example of this. The fundamentals to recognizing this rhythm are firstly a careful check on the regularity of the rhythm. And a very careful check of the R to R intervals on this rhythm are going to show that there's some degree of irregularity, although over a longer period of time, we're going to see a pattern repeat. Secondly, when we look at the P waves in this, we can be assured that in lead 2 they're positive, they're rounded, and therefore we can assume a sinus rhythm. I can recognize more P waves than there are QRSs. So now I know I'm definitely dealing with some sort of advanced heart block. And measuring consecutive PRIs to see if they're getting longer have revealed that I've gone from 240 through 320 milliseconds to 360 milliseconds until the fifth P wave has no QRS associated with it at all. Now, I'm assuming now that the AV node has had some ability to recover, and so the next P wave has generated a relatively short PRI and is associated with a QRS. If we could see this rhythm beyond the end of this rhythm strip, we would assume that this pattern is going to repeat over and over again, and hence, very clearly, we can identify this as a type 1 block. The strongest predictive factors for a second-degree block include age, but it's also associated with patients that have long-term diabetes, chronic hypertension, where there's an existing history of heart failure and or coronary artery disease. As is the case with a first-degree block, the type 1 second-degree block can also be caused by vagal dominance due to athleticism, or this might be secondary to pharmacology, such as the use of beta-adrenergic blocking drugs. So overall, what's the significance of this rhythm to paramedics? Well, in symptomatic patients, the presence of a type 1 second-degree block should always be considered a worrying sign. It may point to the presence of an inferior or posterior AMI if the right coronary artery is involved. And while the incidence of this is rare, it's always a good thing to go back and double check your ECG to make sure that this is absent. The commonest symptomatic presentations associated with a type 1 second degree block is hypotension, and this would normally be secondary to a ventricular bradycardia associated with the underlying rhythm or the degree of the block as it affects the ventricular rate. So it's this that might result in, say, a syncopal symptom with or without loss of consciousness, or the patient may have some form of myocardial ischemia showing up, and this is more likely in the older patient. If the patient is symptomatic and a low ventricular rate is the most probable cause, then the use of pharmacology or external pacing to increase the heart rate would be an appropriate course of action. Some texts state that the rhythm is considered relatively benign, particularly in the young and the fitter client. However, its presence might be associated with some undiagnosed issue. Should the discovery of the second degree block be a new finding, it would always be appropriate to transport the person to ED for further investigation. At the very least, you'd want to discuss this with a senior medical officer to ensure that the correct pathway is going to be followed and that there's adequate safety netting for the case. So this moves us on to second degree AV nodal blocks that are type 2. And the type 2 block is another example of incomplete conduction between the atria and the ventricles. With this type of block, we also see a dropped QRS complex, but we also see a constant PR interval. This block often produces a very consistent AV conduction ratio, and the common ones are 4 P waves to 3 QRS complexes, or 3 P waves to 2 QRS complexes. And this strip here shows a 4 to 3 conduction ratio. So let's reiterate the second degree type 2 block characteristics. Firstly, it's an incomplete atrioventricular block, meaning that some of the atrial impulses are going to be blocked at the AV node and they're not going to go on to create a QRS. So our first clue is going to be more P waves than there are QRS complexes. The second point relates to the regularity of the rhythm, and you'll note in this one that the R to R intervals are much more constant, they're much more predictable, and even predictable as to where the dropped beat should have been. Likewise, the PR intervals are constant and don't alter significantly from beat to beat. As an aside, we can see both a 3 to 2 and a 2 to 1 conduction block on this particular rhythm strip. The final point I want to make about second degree heart blocks is around the presence of what's known as an advanced or a high grade block. Now, advanced blocks tend to produce very slow ventricular rates and will have a P wave to QRS complex ratio of 3 to 1 or higher. Another way to think about this is that an advanced block has 2 or more consecutive P waves which do not result in a QRS complex. Advanced blocks can be due to either a type 1 or a type 2 second degree block, but the concerning factor for us is going to be the low ventricular rate that they tend to produce. This ECG shows a regular rhythm with a ventricular rate of 35 beats a minute, but the atrial rate is 140. The P wave is rounded and it's positive in lead 2, so we're assuming a sinus origin. The PRI on the conducted beats is constant, and the QRS is narrow. So this suggests that there is a sinus rhythm that's driving some of these QRSs, and because there are more P waves than there are QRSs, we're going to assume a second degree block. The ratio of P waves to QRS complexes is 3:1, and hence it's definitely an advanced block and definitely a significant bradycardia. In terms of management, parasympathetic agents such as atropine are generally ineffective in this setting, and external pacemaking and/or the use of sympathomimetic drugs is the normal course of action. So the current qualification structure in New Zealand restricts these skills to intensive care practice. However, you can always initiate a discussion with the clinical desk if you encounter this situation, and that may enable some effective treatment if an ICP is not immediately available. So this brings us to the end of the section where we've dealt with first and second degree heart blocks. The next presentation is going to deal with the complete or third degree heart block. So I look forward to seeing you then. Ka kite.